Welcome to Diagnostic Imaging's Weekly Scan. I'm Whitney Palmer, Senior Editor. Before we get to our featured interview this week with Dr. Inette Bloomfield, attending radiologist at Children's Hospital in Montefiore, about the thoracic imaging findings of multisystem inflammation syndrome in children, or MISC, and what radiologists need to know, here are the top stories of the week. It looks like it may finally have happened. Artificial intelligence has reached an equivalency point with radiologists. Well, to be clear, it's one artificial intelligence algorithm tested in one study focused on breast cancer screening, but the results are promising, according to investigators from Karolinska Institutet. They tested 3 AI algorithms that were designed to identify breast cancers based on previously captured mammograms to see which one performed the best. They published their findings in JAMA Oncology. To make this determination, they examined mammograms from 8,805 women between the ages of 40 and 74, 739 of whom had breast cancer diagnoses. Based on their analysis, the team determined an algorithm that was trained with 72,000 cancer images and 680,000 normal images performed with the same accuracy as the average radiologist. It had 81.9% sensitivity, 96.6% specificity, and an area under the curve of 0.956 for the detection of cancers either at screening or within 12 months. These results, they said, were favorable in comparison to the U.S. Breast Cancer Surveillance Consortium benchmarks of 86.9% sensitivity and 88.9% specificity. Work is also continuing to improve the use of diffusion-weighted imaging with breast MRI. Widespread use has been slower to take off due to concerns over spatial resolution and image quality, and that better spatial resolution is needed to identify the changes in cell density, organization, and membrane integrity that accompany small breast lesions. But a new proof of concept study published in Radiology from researchers at the University of Minnesota has shown that the axially reformatted simultaneous multi-slice protocol, AR-SMS, can produce higher image quality than either standard SE echoplanar imaging or RS echoplanar imaging. By testing these 3 5-minute protocols on a 3T scanner on 30 lesions from 28 women, the team determined AR-SMS outperformed both RS echoplanar and SE echoplanar imaging in both image quality and rank. On the Likert scale for image quality, AR-SMS scored 0.74 points higher than RS echoplanar and 1.31 points higher than SE echoplanar imaging. It also achieves larger anatomic coverage and better image quality. Still, the researchers said it requires robust distortion correction and is not yet commercially available. Consequently, they suggested combining the encoding speed from AR-SMS and the reduced distortion of RS echoplanar imaging for future work. COVID-19 has rightfully captured radiology's attention this year, but it is not the only respiratory disease to gain radiology focus. New evidence was published this week in Radiology Cardiothoracic Imaging that reveals lung injuries caused by vaping or e-cigarette use, called electronic cigarette or vaping product use associated lung injury, or EVALI, leaves signature marks on CT scans. Because the symptoms of this disease are relatively nonspecific, including shortness of breath, chest pain, and other symptoms that could indicate a viral infection, these findings could help radiologists make faster, more accurate diagnoses in younger people, as well as help them avoid unnecessary biopsies. A team from the Mayo Clinic conducted this study with 26 patients who satisfied the criteria for EVALI. They had vaped within 90 days of their symptoms appearing, they had chest imaging abnormalities, and any other diagnoses had been eliminated. Upon examining their CT scans, the team found a common injury pattern: ground glass opacity and consolidation. The second most common pattern resembled subacute hypersensitivity pneumonitis. An acute eosinophilic pneumonia-like pattern and organizing pneumonia-like pattern were much less common. The hope, they said, is that radiologists will be able to identify EVALI and pass their concerns on to referring physicians, who can then conduct a nicotine metabolite test or ask the patient further questions about exposure. In COVID-19 news this week, researchers from the Universities of Ottawa and Toronto published their findings that fewer people are heading to the emergency room during the pandemic, leading to a decline in abdominal CT scans and worsening prognosis for patients. In the American Journal of Roentgenology, the team reported a 46.7% drop in the net number of emergency room visits and a 42% decline in abdominal CT scans between the same 4-week period in 2019 and 2020. For the same period, the number of patients with complications and those who required surgery rose. To make this determination, they examined abdominal CT scans from patients who were referred to radiology from the emergency room. The number fell from 733 in 2019 to 422 in 2020. But the number of scans with positive findings rose from 32.7% in 2019 to 50.5% in 2020. In addition, complications increased from 7.9% to 19.7%, and patients needing surgery increased from 26.3% to 47.6%. The reasons behind this shift aren't exactly clear, but the team postulated that people were putting off coming to the emergency room because they want to avoid potential exposure to the virus. And when they finally do come in, their conditions are far worse, leading to a poorer prognosis. And finally this week, Diagnostic Imaging spoke with Dr. Annette Bloomfield, an attending radiologist at the Children's Hospital at Montefiore, about her recent investigations into the thoracic imaging findings of multisystem inflammatory syndrome in children, or MISC. Not only did she share with us the results of her investigations, but given the time of year with schools beginning to reopen, she said these findings support slow, methodical school reopenings that come with plans to scale back in the case that COVID-19 once again begins to surge. Here's what she had to say. And now, Gina, back to you. Well, if you could, Dr. Bloomfield, please tell us, why is it so important to focus specifically on the presentation of MISC in COVID-positive children?
So children are less affected by COVID-19 as compared to adults. They usually have a mild disease, and many are asymptomatic. On the other hand, MISC, or multi-system inflammation in children, is a rare complication of COVID-19. So far, 570 children were reported across the US. Just as of Friday, there was a report from the CDC. It is a life-threatening syndrome with involvement of multiple systems of the body, predominantly the heart, cardiovascular system. Other systems include the gastrointestinal system, including the liver, the kidneys, the hematologic system, the skin. And kidneys, as I said, may become very ill, and many require aggressive management in the setting of an intensive care unit. So it is different from COVID-19 in children, and it's important to recognize it.
All right. Well, then, I guess what makes it a particularly difficult condition to distinguish, or is it that difficult? I've read certain things that it can mimic other conditions.
Well, initially, when it presented, it was a new syndrome. We didn't have a name, even an appropriate name for it. Cases started to appear in Europe and at the same time in New York, in areas that were heavily affected by COVID, with a little bit of a delay from the initial infection, because MISC, as I said, it's a complication. It's a delayed immune-mediated response of the body to the virus. So initially, we didn't understand what's going on. And the children presented with symptoms that are not so specific, like with fever and abdominal pain, vomiting, diarrhea, which could look like gastroenteritis, like a food poisoning, for example, or even appendicitis, or fever with rash and conjunctivitis, inflammation of the eye membrane, pink eye, that can mimic a viral syndrome. So initially the kids might look okay and not so sick, and many of the children would not be admitted to the hospital, and they would rapidly deteriorate and become very sick within 24 to 48 hours, getting into shock and requiring aggressive management. In our series of cases that we evaluated, about a third of the patients were in fact discharged from the emergency room 2 to 3 days prior to their admission when they became very ill, because they didn't look very sick and they were suspected of having like gastroenteritis or something viral that could be managed at home.
Well, then, speaking of your study in particular, walk me through what you did. Who did you examine, and what in particular did you find?
We evaluated children that were admitted to the Children's Hospital Montefiore during the time between mid to end April to mid to end May, and had imaging studies. As radiologists, we of course focus on imaging studies. So we had 16 children aged between 20 months, that was the youngest, and 20 years. And all of them presented with sustained fever. The majority had gastrointestinal symptoms like abdominal pain, diarrhea, vomiting. Many had rashes, conjunctivitis, and most of them did not have respiratory symptoms or cough like typically is presented with COVID-19. And all of these children had, we looked at their labs as well, all of them had markedly elevated inflammatory markers, and many had abnormal liver function, abnormal kidney functions. They also had echocardiogram that demonstrated myocardial dysfunction in 2/3 of the patients. 4 of them had dilated coronary arteries, which is also a rare manifestation of this syndrome. And of course, as I said, we focused on their chest and abdomen imaging studies.
All right. So from those studies, what, I guess, were the most significant results of the investigation, and what did you see in particular with the chest and abdomen studies that kind of stood out the most, that might help expand the body of knowledge that we have about MIS-C?
On chest imaging, which included chest x-rays and CT scans of the chest, the most common findings were related to the dysfunction of the heart. So cardiomegaly, enlarged heart, was seen in 75% of these patients, 12 patients. Other findings were congestive heart failure, interstitial pulmonary edema, and small pleural effusions. 8 of the children were evaluated for pulmonary embolism, and we found positive pulmonary embolism in 2 of these 8 children. In abdominal imaging, we found findings that were secondary to the general inflammation, but also to the multi-organ injury. We found ascites, fluid in the abdomen, in about half of the patients. We found enlarged liver. On ultrasound, we found echogenic kidneys, which is a finding that you would see with parenchymal injury to the kidneys in about 1/3 of the patients. We found thickening of the bowel walls and thickening of the gallbladder walls in some patients, as well as enlarged mesenteric lymph nodes in some patients.
So given all of that, what does that tell us, I guess, about the course of disease that these children are experiencing when it comes to how they progress through COVID-19?
So initially with COVID-19, as I said before, they may be asymptomatic. We might not even know that they have the infection. The only way to know would be with testing maybe later for antibodies and finding that they had antibodies, that they were exposed, that they were in fact exposed to the virus. And then several weeks after, they would develop these symptoms of initially mild symptoms, usually with fever. That's a common finding that's seen in all patients. And then with other symptoms, and which would rapidly progress to multi-organ injury, shock, myocarditis, injury to the heart, injury to the kidneys, to the liver. And that is something that they would be admitted to the hospital with and treated and managed aggressively with pressors, with corticosteroids, with other medications. And the good thing is that in our series and in other studies, that most of them recover. And in our series, 15 of the 16 during the study period were discharged, they recovered, they did well. What we don't know is the long-term outcome of that. Is there going to be any permanent injury to any of the organs? There's still a lot of things that we don't know about COVID and about MIS-C.
Right. So thinking about the comparison with adults, because, you know, obviously we're talking about MIS-C in children, and this is something that we have seen in pediatric patients. How is this different from the inflammation that we're seeing or the other multi-system impact that we're seeing in adults?
So in adults with COVID, or even in children, mainly teenagers that are affected with the direct infection by the virus, the major primary presentation is with respiratory symptoms, with cough and respiratory distress. On imaging, we see findings in the lungs, multifocal pneumonia most commonly. This was a very uncommon finding with MIS-C, also in our series and in other series. And adults also can present with inflammation of the heart and with kidney injury, and may require some management with dialysis, but it is much less common in adults to have the multi-organ injury as compared to children with MIS-C.
What you said earlier is that, you know, a lot of these children presented and no one even suspected, you know, COVID-19 infection to begin with until a lot of these other things began to develop. What can your findings potentially tell providers then about the need for further evaluation or how they can potentially change management of these children who present with some of these symptoms in the early stages?
So in an area that, in a geographic area that is heavily affected with COVID-19, pediatricians should be aware of MIS-C. And whenever a child comes with this constellation of symptoms, which in regular days we would dismiss, right? The child can have gastroenteritis, viral syndrome, we send them home and reassure the parents. But here we have to think about MIS-C. So we have to evaluate the child, to do labs, the appropriate tests, and according to the CDC guidelines. There are many lab tests, including inflammatory markers and many other laboratory evaluations that can be done, including testing for antibodies for the virus, the SARS-CoV-2 virus. And then accordingly manage and maybe monitor closely, or even consider admitting to the hospital before they rapidly deteriorate and become very sick, and maybe starting management earlier than later.
All right. Well, then thinking specifically then about the radiologist, what is, I guess, the takeaway message or the main thing that the radiology provider needs to know from this study if they are presented with these pediatric patients?
So as radiologists, as pediatric radiologists, we're not used to see sick kids, right? Kids are healthy usually, and the child that presents with what looks like viral syndrome and has a chest x-ray, we don't look for big heart, right? We usually say it's normal, or some kind of interstitial opacity, which could be interstitial edema, we might interpret as a viral pneumonitis. But in this setting, we have to carefully look at the heart and look for subtle changes in the heart size. And if possible, compare to prior x-rays and compare the size of the heart. Has it changed over time? And look for small pleural effusions. They could be really small, but all these could be clues for MISC that we should report to the clinician so they would know what to do.
All right. Well, then stepping back and kind of looking at this from a 50,000 level perspective, or 50,000 foot level perspective, what is the overall importance of having this knowledge? What are the main things that the radiologist and the referring providers need to remember from the work that you've done kind of going forward? And, how should this new information be applied?
I think the clinicians and radiologists, as always, should communicate with each other, and we should always look at the child as a whole and communicate the findings and look at that together with the laboratory findings, with the clinical presentation, as well as with the, to look at where we are. Are we in a geographic area that has a heavy burden of COVID-19? And then just treat the patients and appropriately.
All right. Well, Dr. Bloomfield, I appreciate you taking the time this afternoon. Thank you so much.
You're very welcome. It was a pleasure.
Thank you.